All right, well, thank you very much for your time. Excited to be giving you this talk on what I take to be a brief history of digital phantoms, as I've learned over the years from my fantastic colleagues and collaborators, and sort of touching on what's been happening in the past, what's happening now, and what is the future, and multiple generations that we go through. And I think one of the interesting angles and perspectives that I'll be taking in this presentation is going to be on moving towards digital twins for precision medicine. So special acknowledgements to a number of my colleagues, Dr. Zaidi, Seeger, Saburi, and Maharaj, for sharing of a number of slides and fantastic discussion. So let me go over some aspects of why I think realistic digital phantoms have been very useful in the past, and they continue to be very powerful. So doing radiation protection, doing a number of calculations in the context of internal dosimetry. I'll talk about radiopharmaceutical therapy or molecular radiotherapy a bit later. When you're designing imaging systems and optimizing them, it's nice to have a realistic representations of phantoms. Image reconstruction, there's significant applications. Quantification, image corrections, again, understanding and having realistic representations of preclinical and clinical models is important to see how these corrections work, and for example, in the context of dynamic imaging, kinetic modeling, etc. So just to go through some of the history of this, this research has been going on for well over 50 years. And the first generation of phantoms sort of originating, for example, from the Oak Ridge National Laboratories in the 60s. These are stylized phantoms based on mathematical definitions, which we'll see in a second. Second generation shows up when you move beyond mathematical oversimplistic models. You sort of start looking at real images, for example, and you sort of basically, for example, through segmentation of real images, you start to define and create voxelized phantoms. And also later after that, we had the third generation where phantoms were generated with boundary representations using computer graphics techniques and models, for example, meshes, NURB systems, etc. And there's hundreds of models actually out there. This number is clearly increasing actually, and I'll show some references. So just to really capture that, the models have become more and more complex, more and more heterogeneous, deformable models, moving from a reference man to more representative models, and even moving towards personalized models, which I'll talk about now. So generation 0, which shouldn't, in a sense, even count, is when, for example, you might have had like a sphere, right? And you're doing very, very simple, let's say, dosimetry calculations. How much energy is deposited if this consists of, carbon and hydrogen and things like that. But really, let's refer to this as the first generation stylized, mathematically defined phantoms. And then we move towards rigid 3D models that are voxelized, but they're not really versatile, often obtained by very meticulous segmentations. And finally, you've got some surface fitting and rendering and allowing the organs to, for example, move and being more flexible. And, finally, sort of moving towards personalization. So this, people were really talking about years ago too, but the way we think about it is this is moving us towards digital twins. So true personalization of the phantoms, which will require a very sophisticated modeling of the biology, not merely just anatomical variations, but truly biological and physical variations. And this is the sort of the fourth or the future generation that will be happening. So again, I'm just repeating what I said. First generation, very simplistic models. Moving towards second generation voxelized models. Third generation models, again, for example, our fantastic colleague, Dr. Paul Seegers, has been pioneer in this field. For example, his XCAT phantoms are used by many researchers around the world. And I remember during my time when I was at Johns Hopkins University, he was upstairs from me, and we started a collaboration that culminated in some interesting results and publications. And for example, here's a brain phantom that he built for us based on the sort of segmentations and the data that were provided. And we actually, in that particular publication, we were looking at, motion correction in the context of image reconstruction. So having over 90, close to 100 structures, exist in that phantom that is freely available on our website. Here's another example of his models, showing real patients, simulated patients. I remember this one we actually helped him with. So we provided some numbers in brain PET imaging, and then we ended up doing the simulations and doing some studies. So same thing, except this is from a different group and different set of group of researchers, University of Florida, the UF. So this would sort of be, the original first generation stylized phantom, whereas here would be the voxelized phantom from UF. But you might see discontinuities happening. The human eye easily captures discontinuities here. Therefore, scaling to different resolutions is not straightforward. Whereas if you're having these continuous surfaces fit to these structures, and you can scale these models to different resolutions, and you could use them for many different applications. So this would be second generation. This would be third generation. So some people refer to that as hybrid phantom. So it's not pure voxel, it's not pure stylized, mathematically defined, but using advantages of both. And so this would be the third generation model. So again, very realistic models with, for example, cardiac movements and respiratory movements that have been used by many in different applications that you can sort of see here. And for example, one application would be, well, obviously, if you have a phantom that moves and that models respiratory movements, you can actually study the effect of respiratory movement and motion on radiation doses that are being delivered to patients. Just one example that I'm providing here. And again, different layers of sophistication being added, right? So we've got the vessels and the organs and the bone and muscle and skin and everything sort of coming together. Yeah. I remember once we were writing a grant, and Dr. Siegert was very gracious to create this representation for us. We were actually looking at a totally different application, not even nuclear medicine. We were looking at photoacoustic applications in the brain. So photoacoustic tomography, for example. So again, these are the kind of models that you can have, and you can do simulations. What happens if you shine light through the skull? Can you do imaging of the brain? So, and again, high detail, very high, increasingly high resolution in these models. Here's an example of something you can do on top of these phantoms, for example. So here's an example where Roberto Federico in our lab basically added, in collaboration with Dr. Siegers, added the lymphatic system to the 4DX cat phantom that is freely available, that you can pick up and sort of look at. Looking at pediatric models, which obviously are very important in the Image Gently campaign, where pediatric imaging, you have to really account for those much more carefully, because children have a longer life ahead of them, they're more radiosensitive, and they're smaller. So you have to be very careful about radiation for children. And again, looking at pregnancy and sometimes you have patients that show up in the clinic, they have to be scanned. Unfortunately, even though they're pregnant, they have to be scanned, or sometimes somebody is scanned, but they find out later that they were pregnant. And then the kind of calculations can be made, such as in this really great effort by team of Dr. Zaidi to build these models. And preclinically also, there are a range and a number of models that are out there, the MOBI and the ROBI models for rats and mice are out there, for example. And there are other ones that have been built. There's a lot of different preclinical animal models that are out there for many different kinds of animals and species. And for example, studying different sizes or different ages of animals, this can be adjusted and built. Effect of, for example, obesity, where the ROBI model was taken and then just adjusted to different, for example, weights, etc. And you could also adapt these models for different postures and for different purposes and different calculations. So again, some publications, there are many papers in this area out there. On the preclinical side, especially when I refer you to this really nice book collection, you'd be shocked almost or surprised by how many different animal models are out there. From mice to rats to pigs to dogs to many things that you wouldn't normally think about. So I'll refer you to this very nice collection of works. So let's talk about some applications. And I think just by thinking about these different phantoms, you've already come up with a good number of applications, and we already mentioned a number of them anyways. But just to give you some examples, right? So again, the idea is to go from the real world to the digital world, but it must be a very realistic digital world. And so again, you have amazingly realistic phantoms that are out there, though this realism presently is really at the level of anatomy, okay? But when you start talking about biology, there's a massive gap between what needs to be done and what has been done. So again, just one example application would be you could calculate organ doses from different protocols, whether it's an imaging protocol or different injection protocols. The concept of virtual clinical trials, for example. So instead of purely relying on many patients in a real trial and real acquisitions, you could build a very realistic collection of virtual trials. You can look at this special guest issue section on virtual clinical trials, for example. And this could either be used for initial assessments, followed by assessment on a number of patients, or for certain applications, the future might be to purely rely on the virtual population for certain applications. So again, the idea that very different models and have been built, expanding library that can be used to mimic clinical trials, from adults, different kinds of adults, to pediatrics, different kind of pediatrics. And the Image Gentle campaign is one example I mentioned to you. Just another depiction of that. So here, for example, you see an example of close to 60 patients that have been built that can be utilized for a certain kind of study that you might be doing. And so once you have these realistic representation of patients, then you got to do something with it. And again, the focus has been significantly on the physics, modeling of the physics, not the biology. The biology has been oversimplified, you can safely say, though appropriately for certain applications. But again, the future, the fourth generation, the personalization really needs that biological aspect. But just to quickly overview the physics, simulations of the physics. So once you have a phantom, then you could have simulations of, okay, what happens? Let's say in the case of nuclear medicine, you have radiopharmaceuticals accumulating in different organs. They're going to create events. They're going to create radiation, gamma rays, and you're going to build a virtual scanner, and you're going to do simulations. And again, these kind of simulations are out there for many different kinds of medical imaging modalities. And there have been general purpose and dedicated simulation packages, each with their own pros and and cons, and here are some examples, especially in our own field of nuclear medicine. So the general purpose ones have a wide range of physics, for example. They could be very complex, whereas the dedicated ones are optimized, for example, in very specific nuclear medicine, for example, applications. They might be easier to use. And there are many, and this is not a comprehensive list, but there are many different Monte Carlo software packages, many different non-Monte Carlo analytic codes. And I always like to emphasize, one does not have to use Monte Carlo all the time. For certain applications, it is overkill to use Monte Carlo, and simple analytic non-Monte Carlo methods can work very well. Two examples from our own lab, MATLAB-based, C-based. And again, applications could be looking at, for example, image acquisition strategies, image processing methods. For example, you're going to have a range of realistic phantoms. You simulate tumors in them and different organ sizes. You do imaging, realistic imaging simulation, reconstruction. Then you, for example, test your detection or segmentation method for tumors or for normal organs, healthy organs. So this could be used, or in this example, the application is myocardial SPECT, where it could be varying your reconstruction methods and comparing them. So retrospective dosimetry is something that is a very interesting area of usage for existing third generation phantoms, for example, where you calculate, for this range of different phantoms, what is the radiation that is, for example, delivered to the different organs. And you could sort of plot that as a function of simplistic or just individual parameters like the chest diameter, for example, and see what changes are made. And you can gain better understanding of, what variations in patients are most predictive of how much dose will be delivered to them. But moving forward, what you really want is to do prospective or predictive dosimetry. You want to predict what will happen to your patient. Now that's not easy. And so one idea would be to do phantom matching. You create a whole set of phantoms. And then for your specific patient, you find that phantom that best matches your patient. And then presumably you've done a number of calculations on that patient. For example, dosimetry calculations that if so much radiopharmaceuticals accumulated in such organs, what is going to be the dose to the different organs and tissues. So you could do that. So so that's phantom matching. Also, different patient, real patient shows up, you match that patient to a computational digital phantom, and based on the calculations done on here, you sort of predict how much will be given to this patient, which is important because then you can adapt the dose before the fact, before you do it, right? So again, you could do organ dose estimates using phantom matching because you've done these extensive calculations for the different phantoms. You match the right phantom to your patient and you do that. However, the problem is that these models, again, are being matched somewhat superficially. Again, they might be totally appropriately matched for some applications, but these are often being matched anatomically. And we're not exactly looking at the detailed biology and the physiology. So obviously, and we've talked about this in our own discussions, we need to do more. We need to do more sophisticated pharmacokinetic modeling. We need to do more sophisticated radiation biophysics modeling. We need to look at tumor transport phenomena, multi-scale cancer modeling, to build better models. So just focusing on radiopharmaceutical therapy, for example, which, as you know, has many different names: radionuclide therapy, molecular radiotherapy, which is obviously an area of intense interest in therapeutic nuclear medicine and in theranostic applications. When you're matching the imaging with the therapy, you're really imaging what is being treated and how much is being accumulated. But can you predict before you deliver the doses to the patients? Can you predict how much will be delivered? And it's very important to be able to do so because, especially in the first cycle, when you're injecting after the first cycle, certain events may especially happen, like internalization might change. So that first dose you give can be actually very critical, very important. The body has not created a defense mechanism against it. And so if you can really predict how much dose is going to be lethal to the tumors and toxicity will be kept in control, that first dose predicting how much will accumulate in the tumors is going to be very important. Right, so can you predict? Can you do predictive dosimetry in the context of radiopharmaceutical therapy? Because we do that in external radiation, in radiotherapy. It's totally unacceptable not to predict the dose in external RT, radiation therapy, but presently the practice is not to predict how much is going to be accumulated in radiopharmaceutical therapy. We find that to be unacceptable. And so, you know, in different clinical trials, if you're going to do predictive dosimetry, the hypothesis is that you're going to get better patients' survival. So here's an example of a, you could say, a successful clinical trial in prostate cancer therapy, PSMA, prostate-specific membrane antigen therapy. Many different patients were enrolled. It was a well-designed study in the sense that how they were recruiting patients was very meaningful, which I won't elaborate on. However, it was not doing predictive dosimetry. It was not adapting the dose to the different patients, right? So even though it showed very good results, or good results, 4-month extension of overall survival, our hypothesis is that if you're predicting dose that will be delivered to the subjects, you can actually adapt the dose better. Our hypothesis is that many of these patients are underdosed, and that we could be giving them higher doses safely, and therefore extend survival better. That's the hypothesis, and that's the future, we believe. So to do that, you need to move towards these 4th generation realistic digital or computational phantoms, where you're going to build digital twins, which are numeric representations of a patient. And this is, by the way, has multiple uses. First of all, this numeric representation can also represent the patient, as that patient has undergone treatment and imaging in the course of one's life. So, and it can be updated with real-time data, like cumulative radiation doses reflecting the history. So this would be a nice way for clinicians to capture the essential history of the patient, and can be used for simulations to allow us to do interventions in the virtual world and to ask certain questions in these sophisticated models that are integrating more advanced, for example, pharmacokinetic models beyond overly simplistic models. So a vision of the future that we have is that accurate and rapid evaluation of different, for example, radiopharmaceutical therapies can be done using this. So you could, for example, experiment for a given patient, what would happen if you vary the injected radioactivity, or where you inject, or how often you inject, and how you couple it with other therapies, right? I'll just give you one example. I was taught years ago by one of the postdocs in our lab, Dr. Soltani, who's now an associate professor. What he taught me was that there are a number of studies showing that drug delivery to a tumor depends on the shape of a tumor. If a tumor is spherical versus elongated, how much delivery there will be achieved for a drug varies. So knowing the shape of a tumor, one can predict, at least in relative terms, how much will be delivered. Of course, it's not so simple, right? I mean, there are other variations that are not just about shape. It also depends on the shape of the vasculature in the tumors, right? The status, the genomic status of the tumor. Is it hypoxic? Is it not? And all these things. But my point is, we're not accounting for any of these, right? And we should be accounting. We should be accounting for different aspects of the patient and the tumors that we're trying to target, and the manifestations of the disease, the imaging phenotypes that are giving us ideas about varying doses impacting how much will actually be delivered. So the nuclear medicine digital twin will be able to aid nuclear medicine physicians in complex decision-making processes in this example. And for radiopharmaceutical therapies, we think it's going to allow us to optimize injected activities for maximal impact and minimal toxicity. And including, modeling for things like internalization, which changes between first and subsequent cycles, the sink effect, which is an important effect where the tumor might drain the system, and for example, less radiopharmaceuticals might be delivered as a result to healthy organs, and because of that, you could actually further modify the dose safely to achieve better therapy. And again, to better predict the future, we need improved biological models. We do have very sophisticated models of the physics, but on the biological side, we really need to move further, and we really need to bring the worlds of biology and physics together, moving beyond just pure kinetic modeling paradigm. So I gave another talk, another forum about long axial field of view PET scanners or total body PET scanners. We think those are going to allow us to really move towards digital twins, for example, even better, and that we cannot just rely on simple existing, oversimplified kinetic models, and we need to do better pharmacokinetic modeling. Just saw this paper today show up in Nature Medicine. So they are proposing to build digital twins for predictive oncology, as they call it. We've been using the term predictive dosimetry. Others have referred to it as prospective dosimetry. And the claim here, as we've believed for a while now, is that this will be a paradigm shift for precision cancer care. And so you're going to have models based on which you're going to make predictions for your patients. And through different experiences and trials and studies, you're going to do continuous learning and constantly update these digital twin models. So again, pharmacokinetics, there's a whole world of pharmacokinetic modeling away from imaging in drug development, for example, which is not being incorporated in what we do, because often these have been thought as being too complicated, too sophisticated. But now with improved imaging, with improved axial coverage of the patients at a given time, we believe we can move towards building more sophisticated pharmacokinetic models. And on the other side of the drug, so pharmacokinetics is what the body does to the drug, and pharmacodynamics is what the drug does to the body. In the case of radiopharmaceutical therapy, this is basically radiation biophysics, what the radiation does to the body, which again has to be very carefully modeled, including cellular and microdosimetry models. And there are different kinds of PK models, for example, that have been used in that other literature, the top-down models, bottom-up models, which we've also looked at as a group together. So these POP PK models are kind of similar to our kinetic models that we use, for example, in nuclear medicine. They are oversimplified. They fit the data well, but they're oversimplified. And it is an area of increasing interest to look at these more sophisticated models, physiologically based pharmacokinetic models. Okay, so again, these are sort of the POP PK models, sort of oversimplified, whereas these more sophisticated models, we believe we need to move towards. Yeah, so just as an example, here's an example of a paper we recently published where, tumor transport phenomena are being modeled in a more sophisticated way, right? And the impact of microvasculature. However, in real clinical imaging, we will not have such fine resolution. So we have an inverse problem to solve. And also, we're asking questions, what kind of imaging modalities can be used to further assist us to build these biological models that allow us for each individual patient to build these multi-scale biological models and to create digital twins for each patient. Just imagine a day where we could sort of have a model like this for each individual tumor in each individual patient. Now, it may not have to be so sophisticated. And in fact, it might be almost impossible for it to be so sophisticated, but that may not be needed. The point is, presently, we're not doing anything about that. We're basically giving the same dose to our patients, which is far, far, far away from what needs to be done. So vision of the future requires extensive imaging, which has a lot of value prior to therapy and in the course of therapy. For example, PET, such as long axial field of view PET scanners, maybe adding CT or MR perfusion to understand different aspects of the tumor phenotype and biology, and combined with other kinds of imaging and clinical data. And then based on that, we would be building these digital twins to do predictive and personalized dosimetry for optimal delivery of healthcare to our patients. And we would be coupling these digital twins with appropriate computational tools that can be used, right? So for example, a model can be personalized based on pre and or some of the initial therapy, intratherapy imaging modalities. We could study different injection strategies and intervals, as I was mentioning before, corrective strategies that can be used, combination therapies that can be adapted and personalized for our patients. And some of these intense computations can be simplified or can be performed after the model has become sophisticated enough using AI models. So the AI models can capture very sophisticated models once they've been built in computationally feasible, much more computationally feasible times. So we believe the future is bright and we need to be moving towards this. And so, and I certainly hope that we do. And digital twins seems to be a very important ongoing and future in precision healthcare and medicine. So thank you very much.